Good afternoon, everyone. Welcome to today's SVS VQI Smoking Cessation webinar series. My name is Jennifer Correa. I'm the marketing manager here at the PSO. I'm joined today by Betsy Weimer, SVS PSO Director of Quality. Before I turn things over to Betsy, I do want to cover just a few brief housekeeping items. We will be keeping all lines muted throughout today's presentation, but please type any questions you may have in the Zoom Q&A box. For the Smoking Cessation series, we will not be answering questions live during the event. Instead, we will be compiling all questions and answers and creating a frequently asked questions document. This document will be updated following each smoking cessation webinar and posted on the VQI website along with the recordings and slides from each session. And with that, I'll turn things over to you, Betsy.
Awesome. Thanks so much, Jen. Welcome, everybody, and happy Tuesday. I can't believe it's already the end of August already. So I hope everyone has had a great summer. All right, as always, we do like to go ahead and share our disclosure and disclaimer every month. So this National Quality Initiative Smoking Cessation webinar series is based on my knowledge from taking and passing the CTTS certification course in 2024. Each state, province, and continent is unique and offers their own individualized smoking cessation resources. Insurance reimbursements do vary state to state as well as internationally. And this webinar series is intended to provide a variety of resources and knowledge for all participants of VQI, but not replace expert opinion or treatment for individual patients. And again, our smoking cessation webinar series are held monthly. There's available recordings, slides, resources, an FAQ document, and these are all on a dedicated area on our VQI website, and the hyperlink is at the bottom of the slide there. The webinar dates, topics, and audience are, you can see it on the slide, and this is our 8th month. We have 4 more. So this year has flown by again. I can't believe it. So next month will be held on September 23rd. And here are the topics expanded. This is what we've already reviewed. And then today, our focus is on documentation and evaluation. Looks like a lot, and it is a lot, but we're going to go ahead and quickly cover that. So we're going to start off with a quick fact. Think about this, if it's true or false. In 2014, smoking cessation became a covered benefit in the Affordable Care Act, or the ACA. And this is actually true. In 2014, the Affordable Care Act provided approved covered tobacco cessations at 10 minutes each, and also a 90-day FDA-approved prescription plan. So again, as I shared with you, today's topic is documentation and evaluation. Our key areas today we'll be discussing are insurance, diagnosis codes, documentation requirements, and billing codes. So it is important for tobacco control program staff and other public health professionals to have a general understanding of tobacco screening, cessation counseling, and tobacco treatment coverage, which do vary state to state. It varies payer to payer and also plan to plan. Also want to have a general understanding of the payers that behavioral health providers or organizations are contracted with. And also you need to understand the population that is being served. Insurances. So the coverage of tobacco cessation treatment or tobacco dependency treatment is needed to be able to bill the insurance plan, which is also called the payer for these services. Additionally, it is important to understand which types of providers are able to bill for these services, even if a treatment is covered. There is extensive information on how to access coverage of these treatments in your state. And you can actually find these on the Lung Association website. And those resources are kind of highlighted on the right-hand side, but they're also resource number 1 and number 3 at the end of this slide presentation. Most insurance plans are required to cover at least some tobacco cessation treatment. However, payers can impose barriers that access the care, such as limiting the number of refills a patient can get per year or requiring prior authorization. It is important to understand those requirements as they may result in the provider not being reimbursed. Understanding the coverage can be complicated, but there are many tools and resources to help. The current set of diagnostic codes used in the United States are the ICD-10 CM codes. They were developed based on the World Health Organization, or the WHO, ICD-10 codes. The Centers for Medicare and Medicaid Services, or CMS, and the National Center for Health Statistics, NCHS, developed a new procedure coding system called the ICD-10-PCS for inpatient procedures. These codes are an important part of the billing process. And again, you can see on the right-hand side of your screen that I've placed just a little box with several resources as well. But the assignment of proper diagnostic codes is required to successfully bill for tobacco treatment services. For example, the F17 code series are used when providing tobacco treatment to a person who has nicotine dependence. F17 is a code in the 10th revision of the International Statistical Classification of Diseases and Related Health Problems, or the ICD-10. This code is used to indicate a person's dependence on nicotine. This indication of nicotine dependence is what establishes medical necessity for the tobacco treatment service being provided. And medical necessity allows the providers to actually bill for the service. There is a diagnosis coding guide that can be found in the guides on the right-hand side of your screen as well. ICD-10 codes are the cornerstone of classifying diseases, injuries, health encounters, and inpatient procedures in healthcare settings. U.S. public health officials at the federal, state, and local level rely on the receipt of ICD-10 coded data from healthcare providers to conduct many disease-related activities. The Centers for Disease Control and Prevention, or the CDC programs, use these ICD-10 codes to conduct surveillance, such as chronic disease and injury surveillance, healthcare utilization, healthcare-associated adverse events, for case findings, list to identify cases of reportable cancers, birth defects, disabilities, and overall to provide public use data files for public analysis. A primary user of ICD-10 codes includes healthcare personnel, such as physicians and nurses, as well as medical coders who assign ICD-10 codes to verbatim or abstracted diagnosis or procedure information, and thus are the originators of the ICD-10 codes. The codes are used for a variety of purposes, including statistics, billing, and claims reimbursements. A secondary user of ICD-10 codes is someone who uses already coded information from hospitals, healthcare providers, or health plans to conduct surveillance and/or research activities. Public health is largely a secondary user of ICD-10 coded data. So I hope that kind of clarified a little bit of the diagnosis codes, the ICD-10 codes, primary, secondary, and also the F17 code series for smoking cessation. So regardless of the payer, which is CMS, Medicare, Medicaid, private insurance, the providers need to use the ICD-10 codes and provide documentation regarding the medical necessity and the specifics of what was provided. The goal is to clearly establish medical necessity and ensure payment for services. Diagnosis coding alone is not sufficient, and that is the key here on that slide. Medicare and other payers find improper payments by selecting a sample of claims or flagging suspicious claims and requesting medical documentation from the provider. The claim is reviewed against the provider's medical documentation, which we all know are audits, right? And this is done either in an electronic medical record or even a paper record. So, as such, the following items should be documented within the medical record: the patient's willingness to attempt to quit, what was discussed during counseling or treatment planning, the amount of time spent counseling the patient, tobacco use, what type, the advice to quit and the impact of smoking that was provided to the patient, methods and skills suggested to support cessation, medication management, setting a quit date with the patient, any follow-up that was arranged, and resources that have been made available to the patient. A fundamental decision that influences how a provider codes is whether tobacco treatment services constitute counseling that merits a separate code or will be included in a time-based evaluation and management service code. And this is called an E to M. Now, this should be considered a typical provider visit. An additional decision is whether the tobacco service should be considered an incident to service. And these services are important for achieving a desired outcome, but incidental to the services initially provided by the provider. And I know it's small, and I apologize, it's very hard to see. But again, these were excellent resources for you to have. And they're billing guides for tobacco screening and cessation, federally qualified health centers, and behavioral health integration services. And again, these are all on the resources at the very end of the slide presentation, but I did want all of you to have these. So some important dates for the Affordable Care Act, the ACA, CMS, and also private health insurances that have happened. So March 23rd, 2010, President Obama signed the Patient Protection and Affordable Care Act into law. September 23rd, 2010, the new private plans required to cover preventive services, including tobacco cessation. October 1st, 2010, all Medicaid programs were required to cover tobacco cessation for pregnant women. January 1st, 2011, grant program were implemented to explore ways to encourage Medicaid enrollees to participate in programs that prevent chronic diseases that included smoking cessation interventions. January 1st, 2011, Medicare prescription drugs had the donut hole that began to close, making tobacco cessation medications more affordable for seniors who wanted to quit. Also, January 1st, 2011, Medicare enrollees were eligible for a new prevention and wellness visit, which included tobacco cessation treatment. March 15th, 2012, the CDC launched the Tips from Former Smokers campaign, which was funded by Prevention and Public Health Fund. And I know all of you have seen several of these commercials, and they're still going on today. In fact, they just refreshed their ads in the past 6 months. So those commercials have been going on since 2012, along with that campaign. January 1st, 2013, Medicaid programs that cover preventive services, including tobacco cessation, they received an increase in Medicaid federal matching funds. January 1st, 2014, several things happened. Medicaid eligibility expanded to 138% of the federal poverty level in states that chose to implement Medicaid expansion. New Medicaid enrollees had to have access to tobacco cessation treatments. Also on January 1st, 2014, tobacco cessation medications were no longer excluded from state Medicaid coverage. On January 1st, 2014, coverage for millions of Americans began through state health insurance marketplaces. These plans were required to cover preventive services, including tobacco cessation as well. May 2nd, 2014, the Departments of Labor, Health and Human Services, and Treasury issued an FAQ guidance about what constitutes preventive coverage for tobacco cessation interventions. And October 2nd, 2018, there were new regulations that take effect to expand plans that are not required to cover preventive services or smoking cessation interventions. And that's the one, that was the last one. So I point all of these out for you just to be aware of how far we've come, where we're going, but also to make you aware and to be aware of how everything is going. And, make sure that you know about what's being covered in your state. Make sure you're aware of the most current Affordable Care Act, CMS, and private health insurance updates, such as all of these. And again, these are all located on your resources, where to find them, where to be notified of the most current updates as well. So just a few examples of smoking cessation coverage do include these. These were actually shared by healthcare professionals in my CTTS training course last year, who dealt directly with coding and billing. Again, these are only examples. And I strongly encourage you to check with your billing department, your state, and again, all of your resources available to you to verify. A couple of examples for ACA. Last year at the time, they provided 4 tobacco sessions and a 90-day FDA-approved prescription. One private insurance provided screening. I spelled quit wrong. Screening 2 quit attempts per year, 4 sessions, and a 90-day FDA-approved prescription. Also approved a combo treatment where the prescription was given to the patient. The quit line supplied the patch, gum, and lozenge for 8 weeks. However, the combo required a prescription that was mailed to the patient. Medicaid provided a 90-day prescription in a 1-year period. The combo was allowed, but once again, the prescription was mailed to the patient. Medicare, 1-800-QUIT NOW, the prescription goes to the patient via mail. So again, all different varieties of how prescriptions are provided. Some are called directly in, some are mailed to the patient. So again, it's a complete variety. So, it's hard for the patients to understand, but you have to know these things whenever you're trying to advocate for your patient. So just wanted to make sure that you're aware of the different varieties. Also, the Affordable Care Act requires most private insurance plans, including any plan sold in the exchange, to cover any services or treatment with an A or a B from the United States Preventive Service Task Force, which is called the USPSTF, without cost sharing. So currently, tobacco cessation receives an A grade. And while many plans are covering these treatments, there is still room for improvement. But each state has an insurance commissioner who regulates insurance products, including health insurance in their states. State insurance commissioners can provide clarification on what should be covered in terms of tobacco cessation to insurance companies in the form of what they call insurance bulletins. Commissioners can also provide similar clarification to consumers in the form of consumer alerts. Since this is the insurance regulator, they have additional steps to take to ensure coverage. There is a toolkit that is designed for state tobacco control staff and their coalitions to work with state insurance commissioners to work for better tobacco cessation coverage in private insurance and specifically in exchange plans. This is actually in number 7 in the resource, again, at the end of the slide deck. And I chose Virginia Insurance Commissioner because I live in the state of Virginia. But I just wanted to make sure that everybody knew that each state does have an insurance commissioner. And I learned this, a state commissioner is elected in 11 states, but appointed in 39 states. So as a quick review, the necessary documentation for reimbursement includes the following. You need to make sure that the physicians are documented the amount of time spent, the advice to quit, the willingness to quit, the type of smoking or the product, the medication management, the quit date, and the resources provided to the patient. And again, smokefree.gov is an excellent, excellent resource to have. So I want to make sure that all of you are aware of that resource as well. So evaluation and management. Make sure you develop a plan based on the results of your evaluation of the patient. You need to know the severity of the dependence, measurement of the consumption, severity of his or her comorbidities, and their prior quit experience. And are they ready? Counseling. Have they had professional guidance? What is their stress management? Discuss their triggers. And are there any psychological methods? Coding and billing examples. Again, check with your coding and billing department, but a few of those F17 codes that I shared for the diagnosis coding, here's 3 examples. And then other billing CPT codes, these are a few examples for you. 3 to 10 minutes, you have greater than 10 minutes, a 30-minute, and a 60 minutes. And then keep in mind that there are specific psychiatric smoking cessation evaluation codes as well. And again, just double check with your coding and billing department. And then abstinence. Once the patients reach their abstinence level, you still need to do an assessment after their quit date, one at 6 months and one at 12 months. And then if they kind of fall off the wagon, you need to ensure that you have followed up with them within 2 weeks of them, quote, falling off. Ensure that they are provided counseling, discuss their triggers and also their coping skills. And if they have truly failed their abstinence phase, this is when they have been smoking for 7 or more consecutive days and for 2 consecutive weeks. And if you want to use devices to determine their abstinence, there are several types of those. You have carbon monoxide, urine test, IntelliQuit, Nick Alert, and Nick Quick urine cotinine, and Nick Quick saliva cotinine. Say that 10 times. Carbon monoxide monitoring devices are an effective stop smoking aid. The smoker is provided with visible proof of the damage that CO is doing, and they can actually chart the progress after they stop smoking. Research shows that smokers are likely to make a successful quit attempt if a CO breath monitor is used as part of their quit plan. And these are very easy to obtain as well. The urine test measures the amount of cotinine in your urine. Cotinine is a chemical that your body makes after you're exposed to nicotine. Measuring this is better than measuring nicotine because nicotine disappears from your system within a few hours, but cotinine remains for a day or more. The IntelliQuit mobile app enables cloud-based nicotine monitoring for all tobacco users, including the first-time Juul pod vaporizers and other e-cigarettes, also known as electronic nicotine delivery devices. When you measure it, you can change it. When you measure it, you can control it. The IntelliQuit mobile app enables both the tobacco consumer and healthcare professional to monitor progress. Counting cigarettes or pods is inadequate and biochemically inaccurate. The Nick Alert test strips have demonstrated a high sensitivity for cotinine to assess recent tobacco exposure due to the cross-reactivity. This implies that recent nicotine exposure via passive, active, or chronic use during the 6 weeks will likely be detected by the Nick Alert test strip. If you need to know someone's smoking status quickly, the Nick Quick saliva cotinine screen is the device for you. It's available as a mouth swab or a urine test cassette, and it's a lab accurate test. It's simple, fast, and the results are available in minutes. And with that kind of concludes all of our documentation and evaluation. So we're going to start with just a few questions, just to kind of round out our day for today. So question 1, Medicare and private insurances reimburse tobacco counseling and tobacco treatment interventions for most providers in the medical healthcare fields. And this is true. Question 2. All of these types of participants can use the quit line for counseling and pharmacotherapy except Medicaid, Medicare, uninsured, underinsured, private insurance with no smoking cessation program, private insurance with its own smoking cessation program. So that's going to be number 6, a private insurance with its own smoking cessation program. That is the one exception. Question 3. It is important to document abstinent rates at 6 and 12-month intervals following an individual's quit rate to measure outcomes of the provided tobacco treatment. And that's true. Question 4. Electronic cigarettes are considered an evidence-based tobacco cessation pharmacotherapy. And that's false. Question 5. The quit line will request the pharmacotherapy prescription from the Medicaid participant and fax it to the rational drug therapy. The Medicaid tobacco user will then be able to pick up the prescription from their pharmacy within 4 to 24 hours following the quit line coaching call. And this is actually true. This is one of the examples that were provided in my CTTS training course. Question 6. Assessing the tobacco user's current challenges and barriers to attaining permanent abstinence is a powerful tool for creating a personalized and effective treatment plan. And this is true. And here are all the resources that we covered today. And again, I did highlight them on a few of the slides, simply because I know it was a lot of covering with the documentation and evaluation and coding. But again, we encourage you to ask any questions by emailing me. And again, the slides and recording will be available by the end of the week on the VQI website, right there at the hyperlink at the bottom of the screen. And thank you all again for joining us. We look forward to seeing you in September. Thank you so much and have a great day.